It starts as a simple tooth problem. You think the story ends when the tooth stops hurting, but beneath the surface, it's only beginning. Hidden inside the bone, a quiet shadow expands. Meet the periapical or radicular cyst. Is the most common inflammatory odontogenic cyst of the jaws, accounting for approximately 50 to 75 of all cystic jaw lesions. It is classified as a true cyst, meaning it is a pathologic cavity lined by epithelium.
Radicular cysts are most frequently diagnosed between the 3rd and 6th decades of life. Approximately 60% occur in the maxilla, particularly in the anterior region, while the remaining 40% affect the mandible. The radicular cyst arises from a pre-existing periapical granuloma. Its development is a reactive process triggered by dental caries, trauma, or periodontal disease. Following pulpal necrosis, necrotic debris and bacterial toxins such as Porphyromonas gingivalis and Escherichia coli exit the root apex. These toxins act as inflammatory stimuli, initiating the formation of a periapical granuloma.
Inflammatory cytokines, including interleukin-1 and interleukin-6, activate fibroblasts and stimulate the epithelial rests of molasses, remnants of Hertwig's epithelial root sheath located within the periodontal ligament. As these epithelial cells proliferate, the central cells become deprived of nutrients, undergo autolysis, and form a central lumen. This process results in the development of an epithelial-lined cystic cavity, transforming a granuloma into a true radicular cyst. The cyst enlarges through a unicentric ballooning pattern, driven by 2 primary mechanisms. First, osmosis. The breakdown of cellular debris creates a hypertonic environment inside the lumen, drawing extracellular fluid across the epithelial lining. Second, hydrostatic pressure. The accumulating fluid increases internal pressure, which pushes against the cyst wall. Simultaneously, inflammatory mediators such as prostaglandins and matrix metalloproteinases stimulate osteoclasts, resulting in progressive bone resorption and cyst expansion into the medullary bone. Clinically, most lesions are asymptomatic. As the cyst enlarges, it displaces bone outward. Initially, the periosteum responds by forming new bone, making the area feel bony hard on palpation. In advanced cases, continued expansion causes cortical thinning, producing an eggshell crackling sensation. If the bone perforates, the cyst may present as a soft, bluish swelling beneath the gingiva. Radiographically, the radicular cyst appears as a well-circumscribed, round to ovoid radiolucency at the root apex.
It often displays a thin, radio-opaque or sclerotic border, continuous with the lamina dura of the involved tooth. Lesions are typically greater than 1.5 centimeters in diameter. Long-standing cysts may cause displacement of adjacent teeth or external root resorption. Definitive diagnosis is made by histopathological examination. The cyst is lined by non-keratinized stratified squamous epithelium with variable thickness. Epithelial hyperplasia may give loops and arcades appearance. The cyst wall is made of fibrous connective tissue with a chronic inflammatory infiltrate. Possible additional findings: Rushton bodies in about 10% of cases, not specific or diagnostic. Cholesterol clefts with multinucleated giant cells. Occasional mucous cell metaplasia in the epithelial lining.
Radiographic appearance alone is insufficient. Histopathology is essential for a definitive diagnosis. The differential diagnosis includes periapical granuloma, usually smaller and without epithelial lining, lateral periodontal cyst, linked to a vital tooth. Odontogenic keratocyst, more aggressive with a keratinized lining. Residual cyst after tooth extraction. And inflammatory collateral cyst related to pericoronitis.
Management aims to remove the source of infection and eliminate the cyst lining. Small cysts may resolve following high-quality root canal treatment. Larger or persistent lesions require surgical enucleation and curettage. When the tooth is non-restorable, extraction and curettage may be necessary. Platelet-rich fibrin, or PRF adjunct to radicular cyst surgery, enhances repair. It releases growth factors, PDGF, TGF-beta1, and VEGF that stimulates cell proliferation, bone regeneration, and it results in tissue recovery after enucleation. This case report demonstrates a periapical lesion in the anterior maxillary region. A surgical approach was planned, and complete enucleation of the lesion was performed. Follow-up radiographs taken at 3, 6, and 9 months. Radiographic follow-up reveals a gradual reduction in the size of the radiolucent lesion. These findings highlight the effectiveness of enucleation in promoting healing and restoring normal periapical architecture. The radicular cyst is the most common inflammatory odontogenic cyst. Early diagnosis, accurate histopathology, and proper treatment lead to excellent outcomes and help prevent complications.